Hello, everyone, and welcome to today's webinar, Trauma Verification's October Q&A web conference. A couple housekeeping items here before we get started. First off, you'll see that there's two ways of connecting into audio. If you check in the audio tab on the right-hand side of your screen, you can either join using your computer system, ideally using a headset, but external speakers will work fine. Or you can call into the conference line by selecting the phone call option and dialing into the number queue there. Now, we will be taking questions during today's event. I will be managing technical questions as they arrive, and any questions that you submit to our speaker will be compiled and reviewed after the event. So we won't actually have a little Q&A session today, but we will be reviewing those and following up with you after the webinar. That being said, enjoy today's event, and I'd now like to introduce Molly Lozada, Trauma Verification Program Manager. All yours, Molly.
Thank you. Thank you, everyone, for joining today's webinar. We're just going to go ahead and get started. It's going to be myself today for the presentation. And just some housekeeping information I have to read. Continuing education. To qualify for CE, you must attend at least 50 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim CE. If you have any questions during the presentation or any questions in the information presented today, you can email us at the cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. Understand the processes and standards involved in an ACS trauma verification site visit and how following these will positively impact the quality of care of the injured patient at your center. So with that said, let's go ahead and get started. So for any new participants, just ensure you have a copy of the manual or a PDF copy. And again, I want to just make sure that if you are using a hard copy or PDF, you download a copy of the clarification document and verification change log. Any new information regarding standards or standard changes will be noted in the change log, and any criteria that are nebulous or just need a little bit more information will be captured in the clarification document. And again, those are released monthly. So if anyone is not on our mailing list, please email us at the cotvrc@facs, and we'll add you to that distribution list. So just some resources for trauma program managers and trauma medical directors who are new. Recordings of the webinars, including today's webinar, will be posted on the website. It'll take a few days for the today's presentation to be posted. The stakeholder public comment website is still open for any feedback. That will remain open for quite a bit. Tutorials, again, becoming a verified trauma center for staff, and also putting together a site visit is available. And again, the participant help for anyone who needs to update their personal information with TQIP and the verification program. That is where you need to access that. Just want to announce our newly released or expanded, if you will, FAQ webpage. We just launched that in the first week in October. We just launched that, and we put that also in our monthly newsletter that we have released this. So for some of you who have not taken or have looked at that yet, it is listed by chapter, and there's a little plus sign. And if you expand on that, you click on that, what it does, it just drops down and it gives you the answer. So the standard is displayed, and then, and in some instances, there's a question, and then the response to that. And what we'll do is update that on a quarterly basis or as needed based on criteria changes or clarification updates, which, as some of you know, happen more often than not. So I just wanted to announce that in today's webinar. So that is available as we speak. All questions are pulled directly from the questions submitted. There have been no edits made to the contents of those questions. If your question is not answered today, the question may require more information and will receive a response from ACS staff within a week after the webinar. So just a quick scheduling reminders and updates for folks who are new to the webinar today. We are going to be presenting updates on scheduling and on every other month that will take place in November. So questions regarding, so if anyone has questions in today's webinar about their application, scheduling a site visit, or reports, where's your final report at, you can reach us through the COTVRC@FACS. Again, scheduling updates will be provided every other month starting in November. So some announcements. The next verification Q&A webinar will be Tuesday, November 27th at 12 p.m. Central Standard Time. The deadline to submit any questions for that webinar will be Monday, November 12th, so pretty quickly here. Just a couple more updates. The TQIP conference, as many of you know, is around the corner. I was asked to remind folks that today is the deadline for registration cancellation to receive a refund, pre-order merchandise through the online meeting registration site, hotel reservation at the meeting rate. Again, all of these are deadlines for today. Reservations received after Thursday, October 25th, or after the room block fills are subject to rate and space availability. So if you have any more information about any of those deadlines, please visit the TQIP meeting website. At the bottom here, we're also offering pre-conference workshops. There's a listing of what those workshops are at the TQIP meeting, and by selecting workshops, there's a list of those for pre-conference courses. So we're just going to go ahead and get started with general questions and go through those. So can you please clarify the update to Chapter 16? So as many of you know, we are in our chapter revision process. We're about 18 months in. It's taken a little bit longer than anticipated, and we're continuing to work on those. Thus far, we've only had 2 chapters approved, and there's been more activity as time goes on. So in regard to Chapter 16, Performance Improvement Chapter, it's currently under revision, as I stated. There is a work group already working on that and implementing changes, or working on changes rather. The goal of that chapter is really to align with the topic course, or actually have the topic course align with whatever the new changes are. So we're going to align that. And another big change that's going to happen across all chapters, not just Chapter 16, is that any non-Chapter 16 criteria will be moved to its original origin. So for example, you'll notice in Chapter 16 that there's multiple CDs in there that pertain to other chapters or originate in different chapters, like CD 2-4, that's going to get moved back to Chapter 2. There's a couple in there for Chapter 7, Chapter 8, Neuro, Emergency Medicine, what have you. So again, that is a big change that we are working on, and we're going to work on aligning that. And also the other big plan coming out of Chapter 16, the group is going to work on developing a process to help trauma centers support their PI concepts, issue identification, action plans, loop closure, event resolution. So again, there's a lot that's going to come out of this Chapter 16 work group, and I'm looking forward to that, as I can assure you will as well. Non-trauma center transfers, seeking clarity regarding trauma center to non-trauma center. If the non-trauma center has neuro capability, Orange Book language seems to be a no, and we agree with that. The VRC has historically not approved transfer to non-designated trauma centers. So the VRC has historically not approved designated trauma centers to transfer trauma patients to a non-designated trauma center. Is there any change with the anesthesia requirement for Level 2? There have been no recent changes to anesthesia requirements for Level 1 and 2 trauma centers. The following is still applicable. Again, this is something that is not in the book. It's in the clarification document and the change log. I think it's in both documents. On level 1 and 2 trauma centers, anesthesiologist liaison taking trauma call or taking call must be currently board certified or eligible for certification by an appropriate anesthesia board according to the current requirements in anesthesiology. So there's no change to that. Direct admits, I had a couple of questions on direct admits. Are there any rules surrounding direct admits? ICU to ICU or floor to floor is permitted, but what about transfers from another ED that have already been worked up fully? I am being asked by my throughput committee to gather feedback from you all. I was thinking no, since there may be additional testing required or something missed that a full assessment and the ED would catch, but wanted to gather your feedback for the committee. So it's a great question. We've had several people ask about direct admits. So there are no criteria around regarding direct admits. The VRC recommends patients who have been transferred in with a full workup at another facility be assessed in your emergency department for the opportunity to identify additional injuries. Again, this is probably something as to consider as best practice since we don't have any criteria around these. Direct admits under triage. Are direct admits supposed to be excluded from the matrix method calculations for over under triage? I would assume so, since we really can't activate these patients, but wanted to check. So the answer to this is you may have to do this a couple of different ways. If your trauma center admits a large, for example, if your trauma center admits a large number of direct admits, it may affect your data and ability to accurately review your activation criteria in the ED. You may have to do a few matrix methods to see how it will impact your over and under triage. If it's too large a number, it's going to skew your data. So again, you may have to look at your direct admits separately for opportunities for improvement. There's no wrong way to do it. It's just looking at your data differently by using different matrix. Please explain criteria, ATLS, etc. for mid-level providers who don't respond to trauma resuscitation but participate in rounds. So mid-level providers, as many of you know, the term is in the book as mid-level providers, but we use the terms advanced practice providers, nurse practitioners interchangeably. But in response to this, for those advanced practice providers who participate in rounds are not required to have ATLS. We have no criteria around that. So the only requirement we have around APPs or mid-level providers is that if they are members of the trauma activation team and participate in the resuscitation and evaluation component, that they are required to maintain current ATLS. Orange Book, this is a question about minimum criteria for full trauma team activation. I thought this was a good question. So the Orange Book, page 38, table 2, has a list of the full trauma team activation. It's a pretty lengthy page. So in this case, the GCS less than 9 with MOA of trauma, we have GCS motor equal to or less than 5 in our activation criteria. Is that okay, or do we need to change our criteria to GCS less than 9? So the reason I said it's a good question is that we've had instances where trauma programs paraphrase or leave out one of the 6 components listed here out of their activation criteria. And what I want to stress is that we want to be careful with that, because reviewers are programmed to look at that activation criteria, and they're looking for the 6 minimum that you have that is listed here. They're looking at the verbiage, and if you leave any component of that out, or you paraphrase, or you change that with something else, it is highly possible that they cite that as a deficiency, or during the actual site visit, they'll ask you to revise that. So the answer to this question is that if the center's full trauma team activation minimum criteria, as listed below or as noted in the book, does not read the same as in your activation policy, A may likely be cited as a deficiency. So again, I just want to caution folks on that. A couple of questions about OPPE and FPPE. I realize we did away with the CME, but this is an additional I guess, task for the trauma medical director. We had some discussion around this at Clinical Congress about how that now impacts the trauma medical director doing these OPPEs. So we are aware of that, and we will take that into consideration in our revision process. So what do the ACS reviewers look at from, and I'm assuming this is at the time of the site visit, do they look at the form, the minutes to assure OPPE and or FPPE is taking place for each trauma panel member? So ideally what the reviewers, what happens during a site visit on the OPPE front is that they ask whether or not the trauma center performs OPPE or the trauma medical director performs an OPPE on his or her trauma panel. So the conversation is had. There is an opportunity for the trauma medical director or the trauma program manager to present documentation at that time to demonstrate that the center is in compliance with doing the OPPE. So the reviewers will review the form and or minutes that reflect discussions and or actions regarding, for example, performance or care issues with a member of the trauma panel team. And if there's and then for the specialists who serve on the trauma call panel, we are asking that the trauma medical director have the ability to have input in those discussions and actions. And I think there's a couple of slides that's asking whether or not the trauma medical director has to do it for the other specialists. So in the last webinar, you presented a response regarding OPPE in regards to the annual OPP assessment for all services, trauma, ortho, neuro, emergency medicine, ICU, and the TMD should have oversight. Are these OPPEs to be generated by the trauma program for these other services? And again, I just want to stress that the trauma medical director is not responsible, I guess I should say, to do the OPPE for the other services. We're just asking that they have some insights and some oversight over what is being done in those instances where an OPP will take place. So no, the intent is that the trauma medical director, as I stated, have input regarding any issues identified for the specialty members who serve on the trauma call panel. It is possible that the trauma service or your credentialing office develop a standardized OPPE template for members serving on the trauma call panel to use. So again, if it differs between specialties, that's also acceptable. We just want to know that the trauma medical director is doing an OPPE and he or she is aware of any issues that come up. OPPE, trauma surgeon report card, what is required for a level 2? Any specific data points we need to present at our survey, or is it only required if we identify care issues during our PIPS process? So this is for all levels. There must be an OPPE process. If a performance issue is identified, it must be documented and available during this site visit for the reviewers. Again, if there's an issue, you know, you want to be transparent. You want to show the reviewers that there were issues and it was addressed and how that was addressed. As far as data points go, I listed a few here. And again, I also said that it's not limited to this, so you can expand on this list. Again, this is all driven by your trauma center. So it could be peer review attendance, CME, if that's mandated at your facility. Patient care, medical clinical knowledge, anything to do with complications, mortality rates, participation evidence in evidence-based guidelines, etc. Interpersonal and communication skills, professionalism. Again, the list is endless, so feel free to tweak, add anything you want to your OPPE process. Pediatric admission. At pediatric trauma centers, who should admit patients who need a laceration repair by plastics if plastics won't admit? So this would be based on your trauma center's admitting policy. If this is something that is not currently in your policy, the trauma medical director and trauma program manager should take this opportunity to review and make adjustments to the admitting policy as it pertains to your program and providing optimal care to the injured patient. So who it's going to get admitted to, what service, what injuries, that is going to be determined by your trauma center. Do patients with dog bites to the face needing plastics to repair need to be admitted to trauma, or can medicine admit these kids? So again, I want to stress that the admission policy will be determined by each individual trauma center. The patient may be admitted to trauma or medicine. Again, that is going to be dependent on your admission policy. This will depend on your admitting policy. If the patient is admitted to medicine, which is a non-surgical service, and requires a surgical consult, then you want to ensure that they receive a surgical consult from trauma or plastic surgery. Surgical admissions. If a patient is admitted to plastics, is that considered a surgical admission? Is plastics considered a surgical service? If a patient is admitted to oral maxillofacial, is that considered surgical admission? Is oral max considered a surgical service? So there's a couple of questions around this, so I just kind of put together this little grid here. So patients admitted to any of the surgical services below would be considered a surgical admission. So again, the core surgical services, as most people know, is trauma, orthopedic, and neuro. And again, that can be interchangeable with any of the other surgical services on this list. So in response to this person's question, plastic and oral maxillofacial surgery are considered surgical services. PI meetings. What is the ACS position on recording PI meetings, and what level of detail from the meeting is being sought by the reviewers? What is the acceptable level of detail, whether that's verbatim or paraphrasing acceptable? So I want to be careful with any type of recording in the PI meetings. If you know, what I put on here is that you want to refer to your legal advisor on that. If that's something that you do just to capture your notes, that's, I guess, perfectly acceptable. Again, you want to just confer with your legal team at your hospital. Recordings would not be needed by the reviewers. They don't need to hear that. So the PI meeting minutes do not need to be verbatim. However, it may be summarized so that the reviewers can understand what topics and what were the discussions around that, and what the actions were resulting from those discussions. So if you try to make it if you try to summarize it too much, what happens is the reviewers will not be able to capture any of the information presented. Page 56, the neurosurgeon should have regular meetings, at least quarterly, which should include a neurotrauma-specific PIPS process under the aegis of Multidisciplinary Trauma PIPS program. If this mandatory, given the verbiage is should, and if the neurosurgery liaison isn't present at trauma peer review, do we table the neurosurgery cases? So it's not mandatory. A neurosurgery PI meeting is not mandatory. Some centers have where their specialists have their own performance review meetings, if you will, for ortho, neuro, emergency medicine. It's not unheard of. So if the center does have that, that's perfectly acceptable, and they can report up to or report to the multidisciplinary trauma PI meetings. In either case, if the neurosurgery liaison is not able to attend the peer review meeting, they would need to, or they should, or I guess I should say they can have a predetermined alternate to attend in their place. But I suppose if there's no neurosurgery attendee, the case can be deferred to a later date. Again, that would be determined by your trauma center on how they want to manage that. PRQ question, burn transfers. PRQ, are there standard definitions for the transfer out categories? Would a PD burn patient fall under PD or under burn? There are no definitions for the transfer out categories in the PRQ. If you're familiar with that list, it's a pretty long list of transfers out. So, you know, there's not a wrong answer to this. depending on the injury, if there was an injury of the peds patient or if it was just a burn only, then it could just fall under the burn category. But if it was, if they had a mechanism of injury, it can certainly also be put under the pediatric category. So again, no wrong answer. It could be one or the other. What is the expected response time for surgical subspecialists such as urology, ENT? Can the institution identify situations when a surgical subspecialist is to be at the bedside within 30 minutes? Yes. The institution will define or can define the injuries and time response required at bedside for the other surgical specialists like urology, ENT, plastics, etc. So they can define those parameters of when they want the specialist to respond at bedside. How is TQIP data going to be used during a re-verification visit? Will the reviewers have reports available to them prior to the site visit? Other than knowing the TQIP website, what is the best way for my center to be prepared with TQIP data used during a site visit? This is a great question. A lot of questions in one. So what happens during these site visits is that reviewers are provided what we call a TQIP primary report, and what that is it's a summary of the hospital's TQIP report, and that's going to help frame some discussion around the results and how the trauma center utilizes those results. Trauma centers, what we also ask trauma centers or trauma programs is to, if they have a copy of the full report, to have that available, because again, the reviewers are not provided a full report, which we are in discussions about possibly doing that in the future. But currently, we provide a very summarized report of your output, TQIP output report. So in preparation for the site visit, what you want to do is just be prepared, because what's going to end up happening if the reviewer has that primary report is they're going to want you to walk them through any issues that were identified in your TQIP report, how those were, what did you do, how long has it been a problem, did you know it was a problem, did you drill down, did you use the drill down tool, and then what opportunities were identified. Again, they're going to want to know what you did in respect to those outcomes. Can you clarify what the expectation is from ACS for drug and PTSD screening? What type of documentation and or intervention? There's a couple of questions on this. For level 2 verification, ESPER specifically required for trauma patients with a positive ETOH. So the responses are covered in, I believe, 2 screens here. So there are no ACS requirements for PTSD. I know this comes up. There's not a CD. So a trauma center that does not perform PTSD, that's okay. You're not going to get dinged on this. You're not going to get a deficiency for it. However, what ends up happening is that if you are a trauma center that does PTSD screening, reviewers want to know about it, and they just want to know what your guidelines are and how you're evaluating those patients, what is your course of treatment and management for those patients. Again, no standards around that. It's a recommendation in the book. So again, just want to present that to the reviewers should they ask. For a level 1, 2, 3 trauma center, universal screening for alcohol use must be performed for all injured patients and must be documented. As some of you know, there was a change to that, or I should say a change/clarification to that as follows. It is applicable to eligible patients who are alive and participatory, regardless of activated or non-activated, who meet inclusion criteria with a hospital stay greater than 24 hours, who are admitted to the hospital and are entered into the registry. So we went from having all trauma patients meet that to just having an 80% threshold meet that, that need to be screened. This will include orthopedic and neurosurgery. Any patients with an altered mental status or death should be excluded from the denominator, as these patients can't get screened. So again, that's a clarification and a change to that standard. At level 1 and 2 trauma centers, those 80% of trauma patients who screened screened positive for alcohol use must receive an intervention. What that intervention is going to be determined by the trauma center. Those that are missed in the screening process, in the screening process will subsequently be documented and reviewed through the PIPS process. Again, this is the area where you want to be transparent with the reviewers. So if any patients didn't receive a screening, you want to let the reviewers know about that, or that you have a process in place for capturing those types of patients and demonstrate that to the reviewers. What is the ideal trauma program manager and trauma coordinator ratio in a level 2 facility? Is this based on volume? So a couple of different ways I interpreted this question, and if I did not answer this person's question, please reach out to me. If I understand the question correctly, level 1, 2, and 3 trauma centers must have a trauma program manager, CPM coordinator, directors. Titles are interchangeable for us here at VRC. So in response to that, in a level 1 and 2 trauma centers, TPMs must be full-time and dedicated to the trauma program. In a level 3 trauma center, TPMs do not need to be full-time or dedicated to the trauma program. They can wear multiple hats. In a combined adult level 2 and pediatric level 2 trauma center, the trauma program manager can oversee both programs. And I put on here it's dependent on volume. So if it's high volume combined trauma center, that may impact the trauma program manager's duties or roles. And if that's the case, reviewers will, reviewers may cite that as a weakness if they see that it's affecting their role as a trauma program manager. So again, it's dependent on volume. If the question is being asked about staffing support for the trauma program manager or coordinator or director, that will be determined by the institution and on the needs of your trauma program. We don't have a staffing ratio for that. When a nurse reviewer attends the verification survey, what will she be looking at which is different from the medical director, or I'm sorry, from the MD reviewer, the surgeon reviewer? Will she be focused on nursing practice as well? Describe her function in a survey. So I try to answer this as best I can, because the reason I say that is because nurse reviewers have different styling reviews on what they focus on and what they hone in on, and what also they will review in the PRQ. So nurse reviewers is typically assigned to the following sections, but they're not limited to this. Again, this varies based on the review team setup. Some reviewers, surgeon reviewers like to look at the prevention, so they'll assign themselves to that. So it varies. So this is just one example of what sections they can review. So in this scenario, they're going to review the trauma program managers, qualifications, trauma registry, advanced practitioners, education and outreach, prevention, and PIPS. And what they're, and again, these are nurse reviewers, they're your peers, so you're talking to people that know what you do on a day-to-day basis. So they're going to provide shared best practices, nursing practice as it pertains to your hospital policy. They're going to review that. They're going to review that your program is adhering to the standards of care, the documentation, and also they're going to provide recommendations on how to improve the trauma program and performance improvement process if there's any areas of weakness there. So again, this is different based on the nurse reviewer, and again, the sections that are assigned to them is also dependent on the team themselves. Lifetime board certification. Many neurosurgeons have non-time limited board certification. Can I assume this is acceptable for our survey? Yes. I've heard this called many different things. So what we call it here at the college or at the VRC program is lifetime grandfathered physicians, surgeons meet the standard on current board certification. So if you have surgeons, physicians that are currently boarded and do not have a board expiration date on their certificate, be sure to note that in the PRQ. I realize that there's a very small section on there, but you can actually do kind of like a footnote. So if it's a grandfathered or I don't know, you can do grand and then just put it like a little asterisk and then just put a footnote and one of the other fields where the name of the physician goes. That way it's not a red flag for the reviewers that it's, you know, a deficiency because they're not current in their boards. So again, it's just one of the kind of the tricks or workaround, if you will, to our PRQ, our current PRQ status process. And again, also be prepared, should the reviewer ask to validate that by having a copy of their surgeon's or physician's board certificate or documentation. So you can go into their board and print out a copy of their MOC actually, and it will state on there whether or not they are currently boarded. So again, just want to point that out to, you know, for you to be prepared if you're preparing for a site visit that they may ask you to present something to them. When evaluating the 1,200 admission criteria for a level 1 center, what constitutes an admission? Is it any patient the hospital enters into their registry or only those that meet NTDS patient inclusion criteria? It's the latter. For purposes of verification, it defines an admission as a patient with a traumatic injury that meets the NTDS or your hospital's inclusion criteria, because it can differ or you can have additional data sets, and are captured in your trauma registry. That's what we're looking for, the 1,200 admissions. Do transfer agreements have to be renewed every 3 years? Is this a deficiency? If they are not, we have transfer agreements in place. They do not have an expiration date and have an auto-renew clause in them for each year. Is this acceptable? It would not be cited as a deficiency if transfer agreements are not renewed every 3 years. It's perfectly acceptable to have an auto-renewal clause in the agreements. For best practices, we do suggest that the agreements are reviewed periodically, whether that be quarterly, annually, every 6 months. The reason for that is that we've seen a lot of changes in the CEOs and the leadership staffing, the CEO or your VP, nursing staff, nursing admin. So again, whoever is signing off on those agreements, you want to just ensure that they're up to date at the time of the site visit with your current C-suite folks. So we're going to go ahead and move on to CD-related questions. Trauma surgeon response time. This looks a little daunting, but it's a great question. So this question is regarding the 15 and 30-minute response time. This person's question is, why would we consider a late response for the surgeon if the patient, let's see, my question is, why would we consider this a late response for the surgeon? The patient might not meet activation criteria on arrival and thus be activated later, and why hold the surgeon to a response time when they have not been activated on arrival? For example, patient arrival at 8 and does not meet facility criteria for activation. At 8:30, they have a drop in their blood pressure and they meet, and they team is activated. I would expect my surgeon at bedside by not later than 8:45, that being 15 minutes after activation, as we are a level 1 facility. I would read this in PI to ensure the patient did not meet the criteria on arrival. If they did, then I would PI this as a delayed activation, not a delay in surgeon response time. I agree with that. So to clarify, the attending surgeon's response in this scenario, to clarify, the attending surgeon's response time for the highest level of activation will be tracked. I'm sorry, let me backtrack that. In response to the criteria, the attending surgeon's response time for the highest level of activation will be tracked from the time of patient arrival based on adequate notification from the field. The last piece on this, adequate notification in the field, was missing from this person's question, so I just wanted to clarify that is part of our standard. But in response to this person's question, patients who arrive in your ED not meeting activation criteria, but during evaluation, this changes due to the patient's blood pressure dropping, the highest level of activation is called. The attending surgeon's response time will be tracked from the time the activation was called, not from when the patient arrived, but when the activation was called. This will not count as a delay in the attending surgeon's response time. However, this should be reviewed through your PIPS process to ensure the patient did not meet the activation criteria upon arrival. We are under triage rate. We are over the stated 5% under triage. We have instituted a change, but our reporting year ends 11/30. Will that be sufficient? So I'm gathering this person is having a site visit fairly soon. So to demonstrate compliance with the standard, the trauma program must monitor and track the under triage rate during the reporting year, because that's what we're looking at. We're looking at the reporting year. That being said, during your on-site visit, it is important to be transparent and present your reviewers with current data reflecting the changes that you made to the program and how this will be monitored going forward based on when the change was implemented to the date of your site visit. So I'm not sure if there's a gap there. It could be a 6-month gap or maybe a 2-month gap. I'm not really sure based on the question. It may be possible that reviewers take the limited data, this is the most recent data after you implemented a change, into consideration. So that'll be a discussion you have with the review team. But again, you want to be transparent in that information. Can the trauma medical director meet one-on-one with liaisons and have it count towards the minimum required attendance to the trauma performance improvement committee meetings? And there's 2 questions to this. Can teleconferencing be utilized by surgeons and liaisons to have it count towards their minimum required attendance at those meetings? So the response to the first question is no. It cannot be one-on-one and have that comply to the 50% meeting attendance. The purpose of that meeting is to improve trauma care by reviewing selected deaths, cases, complications, sentinel events, with the objective of identification of issues and appropriate responses in a peer review format. So, so that would be no. The second question, the meeting requirement of 50% attendance may be met either in person, it could be met by teleconferencing or by video. I know there's been discussion that we want to limit the teleconferencing, but I think we've kind of softened that language up or kind of lifted it up, and it is acceptable to have it in either of those formats. Question about limited tier. The rule is that the physician be at bedside within 15 minutes of patient arrival. For patients meeting lower level of activation, can the hospital use the activation time to measure physician response rather than arrival time? For example, patient arrives in private vehicle and enters waiting area for triage. Triage does not recognize that patient meets activation criteria, level 2 or 3, for 10 minutes. Team activated and physician arrived 6 minutes later. Time from patient arrival to physician is 16 minutes. Time from activation to physician is 6 minutes. The first would be a fallout due to processing time for walk-in triage. But if measured from activation would meet a criteria, this would not pertain to the highest level. That is measured from arrival to physician's response. Excuse me. Based on the example provided, review of the fallout due to processing time for the walk-in triage would be reviewed. The attending surgeon's response time to the limited tier activation would be measured from when the activation was called, not from when the patient arrived in the ED or in the waiting area. Sorry about that. Trauma backup call schedule. Level 3, do we need a backup trauma call schedule if our trauma surgeons take call at other hospitals at the same time? Level 3 trauma centers are not required to have a trauma backup call schedule. For CD 7-8, does the ROP need to be from the PEDS ED to qualify for the requirement for PEDS Trauma Center? Currently, it's an adult EM attending. If this is an adult level 1 and a pediatric level 1 center, the pediatric representative from the emergency department must participate in the pre-hospital PIPS program. So if it's level 1 and or a level 1 PEDS, the respective individuals from each of those programs must attend those meetings. If this is a combined adult level 1 and a pediatric level 2. Either the adult or pediatric representative from the emergency department must participate. So it could be one or the other. It doesn't have to be both in that situation. If a neurosurgical department at a level 1 trauma center does not have a residency and the trauma surgeons are credentialed by neurosurgery, does that qualify for our key performance indicators that we have established for the 30-minute attending arrival? We would use the trauma attending arrival. If the level 1 trauma center does not have neurosurgery residents or advanced practice providers for neurosurgery, the trauma surgeon may be credentialed to manage the neurotrauma patient while waiting for the neurosurgeon to respond. However, the trauma surgeon cannot account for the specialist's 30-minute response time. The expectation is for the attending neurosurgeon to meet the 30-minute response time for patients who require neuro consult. So even though the trauma surgeon is may be credentialed to provide care, it cannot replace the neuro surgeon's response to those injuries or when they're asked to consult. So it has to be a neurosurgeon. Level 3, do we need a backup ortho call schedule if our ortho surgeons take call at other hospitals at the same time? And level 3 trauma centers, if the orthopedic surgeon is not dedicated to a single center and they're on call at multiple centers, a published backup call schedule is required. At an adult level 1 with pediatric level 2, does the pediatric trauma come under the purview of the adult TMD? It may, and this differs depending on trauma programs. Again, if it's a combined center, the adult trauma medical director may also serve as the pediatric trauma medical director. What we've seen over time is that most institutions will appoint a co-trauma medical director. I know there's not a requirement for that, but what they do, again, is they'll appoint a pediatric home medical director, but again, it's not required. So the adult TMD can oversee both. Level 2, with only 10 ophthalmology patients in a year and transfer agreements in place, the CD would still be a type 1. Yes, it is a type 1, regardless of the number of patients needing ophthalmology services. A level 2 trauma center is required to have ophthalmology capability. This means that there is a surgeon available in person within a specified time frame who can provide an ophthalmologic consult when requested by the attending surgeon. Patients who require complex ophthalmologic surgery may be transferred to another center that can manage those injuries / patients. So again, this person doesn't need to be in health 24/7. We're asking that if the attending surgeon is asking for an ophthalmology consult, that there's someone available to provide that consultation within a specified amount of time. Our trauma centers, level 1 Ps, required to have a physiatrist if they have speech, physical therapy, and occupational therapy and transfer agreements to inpatient rehabilitation service centers. We don't have a requirement for physiatrists, so there's no requirement for that. So if you have one, that's great. Again, you're not required to have one. And even at an adult level 1 trauma center. Is there a required amount of trauma registrars for level 1 trauma, or is that based on volume? The number of registrars a trauma program is required to have is based on the trauma center's admission volume. There must be one full-time equivalent employee dedicated to the registry available to process the data capturing of the NTDS data set for each 500, 750 admitted patients annually. Now, staffing needs may increase if additional validation and data elements are collected, such as from the National Trauma Data Bank, TQIP, or your state, and also that staffing may increase based on what their roles are, if they're reporting out or processing reports, etc. Again, this is one of the areas that we are focusing our chapter revision process on as well. So there's more information to come as that chapter is approved. So we just have a couple of questions on CME. Does board certification or board eligibility count as a provider's 48 external CME hours? Please review CME requirements for physicians on call panels at the AAST, the STN track did not review the latest CME status. So in response to the first question, the CME requirement changed to 36 hours over 3 years, in which 12 hours may be accumulated each year. So we've lowered the number. And again, this is only applicable to the adult and pediatric trauma medical directors, the trauma program manager for CE, and anyone who's undergone or will be going through the alternate pathway process. For the trauma surgeons, for the other trauma surgeons, pediatric surgeons, specialty panel members, emergency medicine, neuro, ortho, etc., who are participating on the trauma call panel, staying current in their board certification satisfies the CME requirement. For level 1 and 2 trauma centers, 33 hours from the board certification or recertification process may be used to meet that 36 hours. So if your trauma medical director just recertified, they certainly can use 33 hours from their recertification process to meet that. Level 3 trauma centers are not required to comply with the CME standard. So I do know that at the AAST, there was an STN track meeting. I did not participate in that, but this information can be shared with those folks if they have any questions about that. The trauma medical director still needs external trauma CME education, 36 years. Do the liaisons still need external CME? Simple answer is no. CMEs are not required for the liaisons or any of the other trauma panel members, as I noted in the previous slide. Can you clarify the CME changes? Do all of the multidisciplinary attendees still need CME above their MOC? And again, except for the trauma medical director, trauma program manager, and anyone new or previously approved through the alternate pathway, are not required to do CME at this time. Their board certification will satisfy the CME requirement. And we actually eliminated those CME questions from the PRQ. Sorry, I didn't mention that earlier. So the only ones that needed, again, is the TMD, trauma program manager, and alternate pathway. As long as a provider is board eligible, regardless of the length of time, will still fulfill changes to CME requirements. That is correct. So anyone who's board eligible or in the certification processes, that's what the term, or grandfathered or grandfathered, they meet the CME requirement. So I want to apologize for the webinar last month where I caused a little bit more confusion than I wanted to, and I do want to mention that I am working on a presentation for non-surgical admissions, and I will release that presentation once it's been approved, and hopefully that would help some trauma centers to need some guidance in understanding the non-surgical admission process. So I'm just covering a few questions on this, but again, there's a presentation that I am releasing in the very, very near future within the next month or so. Do all non-surgical admissions require the trauma medical director review, or can those meeting a specified criteria be closed at primary level? So the short answer is no, the trauma medical director does not. So the trauma program manager or a PI coordinator or clinical staff can do a primary review to determine the rationale for admission to a non-surgical service. If there were any adverse outcomes, such as a complication or a death, then you may want to consider having your trauma medical director do a second level of review for those missed opportunities. So again, that may differ at some trauma centers. Patients with an isolated injury, such as ortho or neuro, that are admitted to medicine with counsel to appropriate surgical service count as a non-surgical admission. Yes. So because they were admitted to medicine, which is a non-surgical service, it would count towards your non-surgical admission, and it is also acceptable to do that practice. When reporting non-surgical admissions, are the percentages based on national registry inclusions or total state and national registry inclusion? This would be based on your institution's registry inclusion criteria. So if your trauma center's policy is to follow the NTDS, then that would be what we are asking for you to capture. And if your trauma center's inclusion criteria is a subset of that, that takes an NTDS and then tweaks it and adds its own, that's also acceptable. So we don't want two different sets of data points. We just want what you're capturing at your institution. So if your center captures two sets of data points, one for NTDS or your center's inclusion criteria, and the other for the state, we only want those captured by your center, not the state. When admitting a pediatric patient, does having the PEDS assistant medical director as a surgeon negate the admit as a non-surgical admission? So if I understand the question correctly, the assistant medical director is a surgeon. This scenario would not be a non-surgical admission. So if they were admitted to a surgical service, it would not be a non-surgical admission. What do we need to track through PI process and aim to reduce, keep under 10% non-surgical admission or non-trauma admission? Please clarify non-surgical and non-trauma admit. So again, I apologize for the confusion I caused. So to clarify, some centers use the terms non-trauma admissions and others use non-surgical admissions. And I recently saw another term that I didn't list here. I just never heard of that before, but we refer to them as non-surgical admissions. So many centers have revised. So to keep it under 10%, what some centers have done, they revised their trauma surgery service or orthopedic surgery service admission guidelines to include some subsets of trauma patients that have traditionally been admitted to a hospitalist or to internal medicine. For example, some have moved isolated hip fractures to admit those to orthopedic with a consult with medicine, or rib fracture patients are admitted to trauma surgical service with a medicine consult. They kind of just flipped it around to keep that number under 10%. But I also want to make sure that centers realize that having more than 10% of admitted patients is not a deficiency. We just want to make sure that those patients are being reviewed. And this is just a repeat of the prior slide. Non-surgical admission. In past webinars, it appears some institutions collect non-surgical admits as those patients that do not have a surgical intervention. At our hospital, we consider non-surgical admits according to the service that admits them to the hospital, since it is very appropriate to have some patients that do not require surgery. Can you please review the definition of non-surgical admissions? Again, my apologies for the confusion. They're correct. It is not based on whether a patient needs surgical intervention. It is what service they were admitted to. So non-surgical admits are patients who meet the NTDS or your trauma center's inclusion criteria policy and are admitted to a non-surgical service such as medicine, geriatrics, neurology, intensivist, etc. So that concludes today's webinar. Thank you for taking time to join us, and we'll
Excellent, and thank you, Trauma Verification staff, and thanks to everyone for attending today's webinar, Trauma Verification's October Q&A web conference. If you have other questions, feel free to email those to cotvrc@facs.org. And on behalf of Trauma Verification and our presenters, thanks to all for joining us today, and have a wonderful rest of your day.